Is there? He is going to present on outcome of intracameral and intrastromal voriconazole in deep stromal fungal ulcers in South India.
Good evening. Today I'll be presenting the paper on outcomes of intracameral and intrastromal voriconazole in deep stromal fungal ulcers in South India. Fungal keratitis has been a menace that has plagued our country, and it becomes a very difficult task to treat, especially when it presents like this. To put things into perspective, the incidence of fungal keratitis in North America is 10%, the whole of Africa is 38%, whereas India alone has an incidence of 65%. The reason why it's so difficult to treat is because of the limited options that are available for antifungals, the larger molecule size of it leading to poor penetration, and a shorter T-half life leading to lesser concentration in the anterior chamber. Therapeutic keratoplasty has been a go-to procedures in recalcitrant fungal keratitis. However, we need to consider the complications such as spontaneous expulsion of lens, dreaded expulsive choroidal hemorrhage, damage to angle structures, endophthalmitis, and secondary glaucoma. So, can we hit middle ground with intrastromal and intracameral injections? Procedure that included side port construction, anterior chamber wash to remove the exudates, intracameral voriconazole injection, after which the syringe was inserted in the clear corneal stroma and divided doses were given around the infiltrate. So we conducted a study, a retrospective observational study to analyze the clinical outcomes of fungal keratitis after intrastromal and intracameral voriconazole. So the study was conducted in a tertiary eye care center in South India between the year 2022 to 23, and 40 microbiologically proven fungal keratitis patients with endoexudates were recruited, who had underwent AC wash with voriconazole. So a complete history with a comprehensive slit lamp evaluation and microbiological investigations were done, and all patients who were smear positive were started on topical natamycin drops, and larger and deeper infiltrates were started with dual therapy. When we saw no improvement for the next 3 weeks, then we subjected the patient to anterior chamber wash with intrastromal and intracameral voriconazole. Further progression or no improvement, the patient therapeutic penetrating keratoplasty was done in these patients. So when we analyzed these patients, we found out that 70% of the study population was females with a mean age of 53 years, and 55% of them had a history of prior treatment, out of which 82% were already being treated empirically. And the ulcer size at presentation was 2 to 5 millimeters in 77.5%, with a mean hypopyon size of 3.41 millimeters. All patients were smear positive, and culture positivity was seen in 87.5%, out of which 40% was due to aspergillus and 30% fusarium. So only 17.5% had complete resolution with anterior chamber wash with intracameral and intrastromal voriconazole, whereas 82.5% progressed towards therapeutic keratoplasty. Scarring of the graft was seen in 67%, graft reinfection was seen in 30%, out of which only one patient required re-TPK. So bottom line, anterior chamber wash did not, with intrastromal and intracameral voriconazole, did not improve the final outcomes in these patients. So we need to consider the poor prognostic factors such as prior treatment history for more than 3 weeks, larger and deeper infiltrated presentation, the presence of resistant species, and the presence of hypopyon. So what would be an ideal treatment strategy? We would propose timely therapeutic keratoplasty. Time is of the essence in these patients because an early TPK would ensure a better functional and therapeutic outcome, and also prime the patient for a better uptake for an optical graft. We must consider early therapeutic keratoplasty in patients with progression of ulcer in depth or size, with maximal medical therapy, with lesions approaching the limbus or infiltrates due to virulent organisms, and patients with poor compliance. Thank you. So first, the treatment we tried for 3 weeks, and after which 48 hours apart, we gave injections for a maximum of 3 doses. And beyond which we didn't give because the patients were status quo, it didn't improve, or there was progression in depth. So if you would kept giving, mostly it would have perforated, and it was risky to do an anterior chamber wash with deep infiltrate.
So you gave intracameral in all the cases, or
yes,
there was some contraindication?
In all the cases with endoexudates. There were exclusion criteria, basically with severe thinning, descemetocele patient, total corneal ulcer, where directly TPK was done. But in patients who had recalcitrant ulcers with endoexudates, we had subjected them to AC wash with intrastromal voriconazole.
And did you analyze the organisms? Like, was there any difference in the organism in which you did therapeutic keratoplasty?
Yes, most of the patients were due to Aspergillus patients, so they had a worse outcome in our case series.